Good afternoon and welcome to our Oncology Lecture Series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. Special welcome to our in-country managers around the globe, and especially welcome to our new managers in the UAE, Ms. Kimia Moradi, in our office in Abu Dhabi, and Ms. Maria Virginia Valeri, our in-country manager in Venezuela, who are joining us today for the first time. During this interactive presentation, you have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderators in today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Renata Ruiz. Her presentation is titled Skin in the Game, a practical guide to skin cancer referrals and biopsy techniques. Dr. Ruiz is a dermatologist at Baptist Health Miami Cancer Institute. She provides comprehensive dermatological care, including medical, surgical, and cosmetic surgery and cosmetic services. Her clinical interest focuses on treating patients with diverse skin types and tones. Dr. Ruiz earned her medical degree at the University of Massachusetts Chan Medical School in Worcester. She completed an internship in internal medicine in a 3-year dermatology residency at the Warren Alpert Medical School at Brown University in Providence, Rhode Island. Dr. Ruiz is deeply committed to patient education, advocacy, and volunteerism. She has published extensively in medical journals, presented abstracts at medical symposiums, participated in radio talk shows, and led free clinics and engaged in medical missions, trips abroad in many, many circumstances. She is a fellow of the American Academy of Dermatology and an active member of the Skin of Color Society and the Women's Dermatological Society, among other professional associations. Please let's give a warm welcome to Dr. Renata Ruiz. Dr. Ruiz, what a pleasure seeing you once again. Thank you so much for accepting our invitation. The floor is yours.
Thank you. Thank you so much for the invitation. It's a pleasure. So I can share my screen now, right?
Yes, please.
All right. Can you see my presentation?
Perfect.
All right.
It's a go.
All right. So thank you for that nice introduction. And thank you once again for the invite to speak to all of you tonight. And today this is a simple talk, but my goal is really to give a quick practical guide for skin cancer referrals and biopsy techniques. And my goal is really to empower each one of you to recognize, diagnose, and manage, and also know when to refer appropriate cases to dermatologists so that nothing gets missed in terms of skin cancers, of course. I don't have any conflicts of interest to disclose. I should say, however, that unfortunately, a lot of the data that's presented here is going to be US data because I could not find a lot of data like Caribbean specific, but a lot of the data you see here, it's mostly in regards to the US. So here's some of our learning objectives. I'm just going to leave it here for a quick second so you can skim through it. And let's get started. So I think the first question that comes up is, why is this important, right? And this is important because it impacts our patients every day, right? Like skin cancer is the most common type of cancer in the US and globally. Of course, that includes non-melanoma skin cancers and melanoma. Basal cell carcinoma is the most common type, followed by squamous cell carcinoma. Melanoma particularly, early detection is key. It has more than a 99% 5-year survival. And if you see below, like if we detect a little later when the melanoma has reached the lymph nodes, the survival rates drop to approximately 75%, and with distant metastasis to 35%. So early detection is very, very important. For the Caribbean, particularly, skin cancers have been cited amongst dermatoses that increase disability adjusted life years, which is a measurement that combines in one number premature death, and living with illness and disability. So this is something that impacts our patients every day. So it's very important for us to be looking out for them. And for primary care providers particularly is important because a lot of times primary care providers is the first contact of the patient into the healthcare system. So early detection is key. There's been a large US cohort it was an observational study with about 600,000 patients, and they saw that for the patients that the physicians screened for skin cancer, they had approximately 160% more likelihood of having a melanoma in situ diagnosed, and approximately 80% more likelihood of having a stage 1 melanoma diagnosed compared to the patients that were not screened for skin cancers. So when we talk about skin cancers, obviously there's factors that we can change and others that we cannot, right? So for the unmodifiable risk factors, it's mostly about surveillance, seeing these patients more often and detecting the lesions early. For that, it's mostly lighter skin types, people who have a lot of moles, or people who have history of atypical moles, people who have either personal or family history of melanoma or non-melanoma skin cancer, immunosuppressed patients, which here at MCI, it's a lot of our patients, and I want to highlight particularly solid organ transplant patients that have 65 times more likely risk of having squamous cell carcinoma. So very important to be looking out for those lesions. And of course, people with genetic syndromes that make them more predisposed to skin cancers. The modifiable risk factors, however, those are very important for us to educate our patients, because we can hopefully prevent a lot of those skin cancers, especially when we educate them and start early. And if you look at that list, most of it really is related to UV exposure. So tanning, outdoor work, intermittent sunburns, lack of sun protection, all of that goes back to UV exposure, right? And then for squamous cell carcinoma, smoking is also a modifiable risk factor. So, okay, you have this patient in your clinic, and you decide to take a look at their skin, but what exactly should you be looking for? So I'm going to briefly talk about the 3 most common types of skin cancers we see. As I said earlier, basal cell carcinoma is the most common type of skin cancer in the US and globally. Usually you'd be seeing that in sun-exposed areas. Typically presents as pearly bumps, we call papules, road borders, telangiectasias, which are these overlying vessels that you can actually, this pictures here, you don't see the vessels so well, but also pigmented globules that you can see here on this first picture and this 5th picture. Those are very classic signs of basal cell carcinoma. There's different subtypes. The different subtypes will also have, some will be a little more aggressive, others less aggressive, but all of those are types of basal cell carcinoma. One important point here is superficial basal cell carcinoma, similar to superficial squamous cell carcinoma, can mimic eczema or other dermatosis. So if you have a patient that you've been treating for a while, and for eczema or psoriasis or other dermatosis, and it's just not going away or getting better like you expect, it's worth biopsying, because it might be a little basal or squamous cell carcinoma that's hiding in there. So the second most common type of skin cancer we see is squamous cell carcinoma. Similarly to basal, it's most commonly seen in sun-damaged skin. Typically presents as this rough, thick skin. Sometimes you might see patients complaining of tenderness, lesions that are not healing. And similarly to basal cell carcinomas, there's different subtypes. Some are more aggressive than others, and that will affect how you manage it. And of course, melanoma, which is the one we worry the most because it is the deadliest form of skin cancer. It can develop as a new lesion, which is actually more common. Approximately 80% of lesions that are melanoma are de novo, but 20% of lesions can also be from an existing lesion. So it's always important to also look for change in lesions that are have been present for a long time. So when to worry about a melanoma? I think the ABCDE is something that's important for both us clinicians and also for us to educate patients, because they do self-skin exams as well, and for them to know what's worrisome, what should they be looking out for. So A stands for asymmetry. So if you were to cut a lesion in half, when one side looks like very different than the other. B stands for border. So when the borders are irregular, scalloped, ill-defined, you cannot really know when the lesion starts or ends. C stands for color. So lesions that are very dark, or lesions that have multiple color within it. Or sometimes if you see like white, red, blue, those are not usually colors we love seeing in lesions. D stands for diameter. So lesions that are larger than 6 millimeter, which is a pencil eraser size. And E, which is the one that I tell my patients, like, this is the patient's input is very important because they see their skin every day. We don't, right? So E is for evolution. So if you see a new lesion or something that is growing, changing out of the sudden symptomatic, all of those signs, they do not mean you have a skin cancer, but it means that it warrants further evaluation. And then my favorite sign to look for is the ugly duckling sign, because a lot of our patients sometimes have so many lesions that it's hard to know what exactly is worrisome, right? So if you see this picture here and this patient's back, you can see that all of her moles, with one exception, are similarly colored, they're symmetric, they're small, but there's one that just looks different. So I would look at that one a little more carefully because it looks different. So, okay, you looked at the patient's skin, you found the lesion that you're worried about. And what do? Do you refer to the dermatologist, or do you biopsy the lesion? That answer, it's not so straightforward. That's going to depend, of course. It depends on both, one, your comfort level, right? Do you feel comfortable biopsying the lesion? And also, how easily accessible are dermatologists to you where you're practicing, right? If it's more easily accessible, of course, potentially the doctors will be referring more. But if not so much, then you'd be the one that would likely be doing the initial diagnostic biopsy. And I'm going to go over biopsies a little bit later. Important thing is, if you biopsy, you're gonna want to know how to treat too. So a good reference in terms of treatment is either the NCCN guidelines for melanoma and non-melanoma skin cancers from 2024, or the American Academy of Dermatology guidelines from 2022. I just wanted to put this quick plug out there without talking about any companies in particular, but you might hear patients asking about it. Here in the US, I definitely am seeing patients asking about it. And this is a new FDA-approved device that has artificial intelligence as risk assessment with it. And it's a device that assists in the detection of skin cancers. It has high sensitivity. It's non-invasive. It can be used in daily clinic. However, it's very important. This is designated for triaging, and it's only intended as an adjunct. So it's another tool in the toolbox, but it does not replace the physician's exam, and most importantly, it does not replace histopathology confirmation. And of course, availability and insurance coverage will vary. So if you do decide to biopsy, I want for you, if you take something from today's lecture, this is it. It's very simple, but very, very important. If you do decide to biopsy, make sure to take photos and document appropriately, and to label the specimens clearly and precisely. So photos, I recommend at least 2. If you have dermoscopy available, 3. But two photos would be, one is a distant shot, so you can know the general location of the lesion. So when you're referring to the dermatologist or the surgeon, so that they know exactly which lesion you took. So a farther away picture, and another one closer to the lesion, so we can see the morphology and the color. And of course, if you have a dermatoscope, a dermoscopy picture would be nice as well. If you biopsy a pigmented lesion, ideally we should be aiming for the entire lesion. However, sometimes lesions are really large and it's impossible to get the entire lesion. So sampling at least the most atypical, darkest or most irregular area. And again, I said before, but I'm going to repeat, take some time on your biopsying to label the specimens clearly and precisely. Here at MCI, lots of patients would do like 4 or 5, sometimes 9 biopsies. You do not want to be in the position that you do 9 biopsies, you have one come back as a melanoma, 2 as a squamous cell carcinoma, others benign, and then you need to go back to treat the lesions and you don't know which one is the melanoma, which ones are the squamous cell carcinoma. So photos and correct labeling is very, very, very important. So taking a quick detour here to talk about biopsies. So can the type of skin biopsy affect the correct staging of melanoma? It definitely can, because the depth of the melanoma is very important in staging. So how we stage melanoma, similar to how other cancers are staged, is using a system called the TNM system. T is for tumor, N is for node involvement, and M is for metastasis, but which is what it's displayed on the table on the left. The table on the right shows the T stage, which stands for tumor, like I said, and for melanoma particularly, it mostly has to do with tumor depth. So how you sample in finding out exactly the depth of that melanoma will be key in determining the T stage, which will later help us plug into the TNM staging and find out the stage of the melanoma for that patient. Not only that, as you can see here, the thickness will help us determine how big of an excision we need, like how much, like the size of the margins that we need for to excise based on how thick the melanoma is. As you can see in the diagram on the left, the each stage, it's like it gets deeper and deeper. But if you can appreciate there, a T4, like thickness, like 4, right? The highest T stage, it's only 4 millimeters. So we're really not talking about something super thick, right? Less than 5 millimeters, right? But the biopsy will certainly impact. So the end stage, it's about node involvement. So we need to know when do we have indications for sentinel lymph node. And again, tumor thickness here is also important, because if you did a biopsy and it's like the tumor is it's deeper than 1 millimeter, sentinel lymph node biopsy is indicated. However, sometimes even for thinner melanomas, less than 1 millimeter, if they have the high risk features such as ulceration, high mitotic rate, or lymphovascular invasion, a sentinel lymph node should also be considered. When we talk about sentinel lymph node, I wanted to put this diagram just to give you a little bit of a background of how this is done. This is usually, at least here, it's done by our surgeons, the surgical oncologists. But what they do, they inject dye in the area where the melanoma was removed, and that the dye will be drained by the lymphatic drainage. And then the first lymph node that it hits, that is the sentinel lymph node that will be biopsied. So with the assistance of a probe, the surgeon will detect which lymph node that is, and they will cut that out and send to pathology to see whether or not we have local mets. That is going to impact not only the staging, but also the determination of whether or not the patient needs, in addition to surgery, other treatments such as immunotherapy. Thankfully, most melanomas are diagnosed in stage 1. They're very thin melanomas, but there are some melanomas, a significant amount still in stage 2, 3, and 4. And immunotherapy has really changed the landscape in what we do and patients' survival and prognosis. So the different types of skin biopsies include shave, punch, incisional biopsy, and excisional biopsy. So here you can see on the left what a shave biopsy is, and on the right, a punch biopsy. Both are very commonly done in a dermatology clinic. For shave biopsies, you can use different instruments. The one in the diagram there is a dermablade, which is what I use for shave biopsies, but some people use a regular blade, other people use scalpel. It doesn't matter which instrument you use, however, it's usually a broader biopsy, but it's more superficial. So most people, when you're doing that biopsy, you get a little bit of the entire epidermis, and you get a little bit of dermis. You can, however, do a deeper scoop and get a little bit more dermis, but it's never going to be as deep as punch biopsy. However, you can horizontally, you usually can get a little bit more than you would otherwise with a punch biopsy. The punch tool, however, it's this circular blade that we have it anywhere from like 1 millimeter to 10 millimeters. And you just press it against the skin, you rotate, and you get this coarse sample that includes epidermis, dermis, and subcutaneous tissue. So the advantage of it, you have the full thickness of the skin. So for the T staging of melanoma is very helpful. So a lot of times this is our what we go for in terms of biopsy for melanomas. One important point here, however, as I said, the tool for the punch biopsies go to 10 millimeters. So for very, very large lesions, sometimes it's challenging to know where to biopsy, right? Because if you biopsy in the incorrect location, you might misdiagnose. And you might think it's not like if you biopsy in the correct location, you might get a negative sample result, and it might still be a melanoma. So just a brief comparison between shaves and punch. Shave, again, is more superficial. It's better for raised lesions. It's used by secondary intent. It has good cosmetic results, but I would claim that actually both has good cosmetic results. But it's not a full thickness sample. Even though you can do a deeper scope, like I said, it does not get full thickness. Versus punch, you will get the full thickness, but you will need the punch biopsy tool for it. You might need stitches to close. It works well for both raised and flat lesions. Although there's the challenge, like I said, that knowing where to biopsy to get the correct diagnosis, you do have the advantage of sometimes being able to do multiple biopsy and mapping the lesion when it's a larger sample, larger lesion. And it's preferred by most people for melanoma. An excisional biopsy, which is, I would say, like the gold standard, like in derm residency, this is what we learned, that we should biopsy all the lesions that are concerning for melanoma with an excisional biopsy. However, this is important that it's not a sampling. You really are removing the entire lesion. So you're getting the entire lesion with a little bit of margins. So with this, because you're getting the entire of the lesion, there's no sampling error. So you're going to get a more accurate diagnosis. However, being realistic in a day-to-day clinic, when you're seeing lots of patients, it's very, very hard to do an excisional biopsy because this is time consuming. This is an actual excision, right? So it's time consuming. It requires a stereo setting and wound closure, and also leads to a larger scar. So it has caveats, and it's not for everyone, right? As I said, larger scar. One other important point is because you're removing the entire lesion, it might actually impact the sentinel lymph node biopsy for the surgeons later when they're going back to cut the melanoma out, because since the entire lesion is out, it might be harder to know where to inject the tracer dye. And not only that, with the surgery itself, you might change the lymphatic drainage a little bit so that the dye might not go necessarily to the sentinel lymph node, and that will impact the sentinel lymph node location, which impacts your staging. So we learned that this is the gold standard, but everything has pros and cons. So it's important to consider all those things when you're deciding which biopsy technique to use. So in summary, shave biopsies are preferable for lesions with low suspicion for melanoma, although depending on the lesion, if you feel like you can do a deeper scoop, you can definitely use a shave sometimes for melanocytic lesions as well. Punch biopsies is the one that's the preferred choice for most melanomas. just like in the basic clinic, like I alluded to. However, the excisional biopsy, it is the most accurate. It avoids sampling error, but it may affect sentinel lymph node biopsy, and it will lead to a larger scar for the patient. So getting back out of the biopsies a little bit. So if you're seeing a spot of concern, how do you communicate that to your patient? I think it's very important to just like normalize the referral. Just say like dermatologists see this all the time, and this spot worries me because it seems new, changing. Skin cancer is highly treatable if caught early. Let's just get it checked before it becomes something bigger. And I think if you normalize, most patients are very accepting of it. And then, as I said before, patients see their skin every day. We don't. So it's important for us to educate our patients to do self-skin exams. I tell my patients to do at least once a month a self-skin exam, and have someone who lives with them to help with areas that are harder to look at, or use the assistance of a mirror, like you can see in the picture, to look at the back, look at in the inner arms. Don't forget to look at the bottom of the feet, and have someone help with the scalp. And if the patient notes something that's new, changing, or just feels off, it's always worth getting it checked. I wanted to talk about this briefly because this comes up often, both from friends and patients. It's the concern of sunscreen being absorbed in the bloodstream, and having an impact in our health, as well as the concern with sunscreen impacting our environment. So there is some truth to it, but it's not all true. So it is true that there's been some of the chemical filters, not all the sunscreens, right? Some of the chemical filters, such as oxybenzone and avobenzone, for example, have been demonstrated to be in the bloodstream, like to show some systemic absorption. However, there's no evidence of harm at the absorbed levels. Okay, so that's very important to tell our patients. And then the environmental impact, also there's some truth to it, because there's some studies that shows that some chemical sunscreens such as oxybenzone and octinoxate can impact our the environment and our coral reefs. In fact, that has led to ban of some chemical sunscreens in places such as Hawaii and the Keys here in the US. However, it's just for certain chemical sunscreens. So what do I recommend to my patients? I tell them, if you're concerned about systemic absorption, or if you're concerned about the impact in the environment, just go with the mineral sunscreens. Mineral sunscreens are the ones that have either zinc oxide or titanium dioxide as the ingredient. They're safe, effective, and they're reef friendly. Okay, so you can avoid the problem altogether. Other characteristics of sunscreens that are important. The American Academy of Dermatology recommends SPF 30 or higher. I always tell my patients 50 or higher, but 30 or higher is good. Daily use, water resistant. Those are characteristics of sunscreens that we look for. And also it's important to remind patients that sunscreen is just one part of total photo protection. However, sun protective clothing is also part of it. Hats, sunglasses, seeking shade, avoiding the sun in the worst hours of the day. So like going in the sun like early in the morning or late at night. Those things can also help in the full picture. And then when I have not yet convinced my patients, although this doesn't speak to skin cancers particularly, usually patients are convinced when I show this picture. This is a picture of a truck driver who his left side of the face was exposed his whole life as he's driving, the right side not so much. So you can clearly see here that UV damage has a huge impact in our skin, in aging, and of course in skin cancer. Some common patient myths that I hear in my clinic often. Some of my patients say, but doctor, I only tan, I never burn. There's no such thing as a safe tan. Anytime you're seeing tanning, that means that there was some DNA damage, and the melanocytes are producing melanin to try to protect itself, to try to protect the DNA. So safe tan does not exist. Some people say, oh, but skin cancer is only for older, light individuals, right? Partially true, because it is true that it's more common in those patients. However, anyone at any age and any skin type can get skin cancer. In fact, Bob Marley died from an acromelanoma. Also, unfortunately, because of this I think, common thought in the population, Hispanics and Black patients are often diagnosed at later stage with lead to worse outcomes. And then some patients think that if it's not raised or bleeding, it's probably fine, right? Not necessarily. A lot of the skin cancers are actually asymptomatic. So when to refer to a dermatology, like those patients I would refer, I would not try to biopsy myself. But if a lesion is changing rapidly or has worrisome features, patient with a history of melanoma or dysplastic nevus syndrome, if you got some biopsy results that are uncertain, lesions in high-risk areas such as scalp, face, genitals, or in the nail, or immunosuppressed patients. If you're referring, document clearly with a photo and good lighting, including your referral, your level of concern. And if it's something that's rapidly growing or bleeding, I like people know your referral, and even like if you can reach out to the doctor directly so your referral can be prioritized. And if you're not sure, just send to the dermatologist, because I'm sure most dermatologists would rather take a second look at a lesion or over biopsy than miss a melanoma. So here is just the last few slides is just a few cases. So I'm just going to put the picture. If you can just think of what you think the diagnosis is. I'll give a few seconds and I'll move on. So what do you think this is? So this is pretty classic basal cell carcinoma. If you can see, it's a classic pink pearly pap. You can even appreciate a little bit of the overlying telangiectasia there. So how about this one? Think about what the diagnosis is. This is a little trickier. It can be a few different things, but this is actually a well-differentiated squamous cell carcinoma. So this is a pink scaly pap. You can even see a little bit of an ulceration there. How about this? Think for a second what you think this is. Actually, just put this one to trick. This is actually a sebaceous adenoma. Not every lesion you're going to see, it's concerning, right? I mean, you might still biopsy to confirm, but this is sebaceous adenoma, which is a benign neoplasm of oil glands. An interesting fact about this particular benign neoplasm, it's the most common benign neoplasm associated with a syndrome called Muir-Torre syndrome, which is a subtype of Lynch. So when we see this, sometimes we do some special stains, and if those are missing, we refer these patients to GI and genetics because it increases colon cancer risk, but it's not a skin cancer. So how about this? Think about what the diagnosis is. Not as clear, right? But this can be a few different things. I feel like this is a good case for squamous cell, it's a good case for basal, but I think hopefully if you see that, you definitely either biopsy or refer to the dermatologist, but this is actually a basal cell carcinoma. See, here you can see a farther away picture, close up, and the one on the right is the dermoscopy picture. And this lesion looks, it's pretty well defined, which goes for it, but it's pretty dark, right? So it's actually just a pigmented septum, but it's so dark, that I can see it being concerning without, like, in the regular clinic. So biopsy is fine there. Here, the left picture is the close up, and the other one is the dermoscopy. Think about what you think the diagnosis is. So this is another little basal cell carcinoma. It's a little trickier because it's pretty ugly looking, but you can see the pigment globule. It's this brown area in the dermoscopy. You can see the overlying telangiectasia. Here, think for a second of what you think that diagnosis is. This is actually a very challenging case. I biopsied, not the morphology of it doesn't look super concerning, but it was mostly the history of the patient that's the reason I biopsied, and it was actually a melanoma. So listen to your patient, okay? Sometimes you might look at a lesion, yeah, it doesn't look that concerning, and actually this is a spitzoid melanoma that was biopsied mostly because of the patient history was just off. And then if you can identify here which, if any, it can be more than one, lesions are melanomas here. And the top pictures are the morphology, and the bottom pictures is the dermoscopy. So the first and third are melanomas. And you can see like the first one, it's this like ill-defined, both of them really, but the first one is like the ill-defined borders, pink, brown, and the last one you can also see like the wine chine structures in the dermoscopy pictures underneath. The center one is challenging in the picture, but if you're seeing person, it's a little easier. But you can see it's more symmetric. It's this hyperpigmented halo with the central scarring. And in person, you can also touch it and you'll see that it's firm, and it has the classic dimple sign when you do press it laterally. But that the center lesion is a benign dermatofibroma, which is a scar type lesion, and the other two are melanomas. So this is just a quick summary of the tips, my references, and that's it. Thank you.
Thank you so much, Dr. Ruiz. What a brilliant, brilliant presentation. You had me sweating at the end, but I should tell you that I did very well. You should be proud of me. I did 9 out of the entire session. So that was phenomenal. I love those pictures. And I know that the students that have logged on felt the same way. I guess practice makes the difference in all this. But you did mention something at the beginning that I want to reiterate, although you started by saying that this is a very simple presentation, far from it, because the complexity and the actual ramifications of not diagnosing on time and not necessarily doing the right thing at the moment that is identified, the complications and consequences for the patients can be dire. So thank you for pointing that out. You did mention that 160% of the time, it is a PCP, the primary care, or someone that is actually managing the patient, not a dermatologist, that assists in the opportunity to detect these ailments. So there is one question before we continue, and just as a courtesy of the person that posted it, Dr. Tamargo is asking, with all the information in recent years regarding the toxicity of sun protection products, what is considered for recommended as safe to use? And you did point out, as she was typing, the response to it. Do you want to recapitulate in regards to
Yes,
sunscreen for all
absolutely.
of us?
That is why I brought that up, because this comes up honestly every day in clinic, and even when I'm at home with friends, they always ask because this everywhere in the news. So yes, there's some truth to it, like you saw in the presentation. Some chemical sunscreens have been shown to be in the bloodstream, so there is some systemic absorption, but that has not been proven to have any harmful consequences. So the claims that they causes hormonal imbalance or it causes cancer, that has not been proven, and that's untruth, right? And then in addition, there's some impact in the environment, but again, it's only with some, not all, some of the chemical sunscreens. So just to briefly say the difference between the chemical and the mineral sunscreens, the chemical sunscreens usually they absorb the light, and there's like this chemical reaction that happens, and that's what makes you like protect from the sun, so it's absorbed by the skin. The mineral sunscreens, they're more of a physical barrier, they don't really get absorbed, so they're less. That's why we don't see mineral sunscreens in the bloodstream when we would do, if we were to do that same study. So but to answer the question, my recommendation is mineral sunscreen, so either zinc oxide or titanium dioxide. That way you'd avoid that problem, both for the environment and in terms of systemic absorption. At least that's what we have so far. In the future, with more knowledge, but that's the
Correct.
recommendation so far. The other things I just want to emphasize: SPF 30 or higher, water resistant, broad spectrum.
And consistently use it. We learned the hard way, especially bald people like me. We must protect our skin. Doctor, you did mention, obviously, we're all, as physicians, we're always very concerned of these changes in coloration of the skins, and especially if they're flat surfaces and they might look like nevus and not necessarily malignant. But just to reemphasize how important it is, especially in one of your slides that you said, you must know your skin. You must redocument or have someone else look into it. And sometimes we do a disfavor as physicians, and we do not necessarily take the time to, when we're doing an anamnesis of the entire patient, we do not look at the skull of the patient, at the feet, at the palm of the hands, and other areas in the body where something might be lingering that we do not know. Have you noted these type of behaviors by primary care physicians or other physicians that just dismiss and later on to identify that they have issues pertaining to skin?
Uh, I mean, unfortunately, I think with the healthcare system, I think we're seeing more and more patients, right, in less and less time. So sometimes it's not even that the physicians are just being dismissive. It's just that there's sometimes not enough time to address everything, right?
Right.
So sometimes you're not even doing the skin exam because there's so many other things to cover. So yes, I have seen that, but not, again, not because the physicians are neglecting it. It's just that it's
Sure.
just too much to cover, unfortunately.
Sure, and to my point is that you mentioned you have to be your own advocate and care for your skin. Simply put, protect your skin from sun, especially if you have light skin and history of melanoma and other stuff that you mentioned as risk factors. But one thing to point out, especially because you are in the oncology center, that you deal with this day in and day out, and sometimes you might see it more often than other physicians. It's the fact that you do have patients that are immunosuppressed, that are receiving these type of medications that will end up immunosuppressing patients, and then it will translate into skin conditions that need to be looked at. And also, you mentioned, important to actually recapitulate, is the fact that those patients that are already received or have received transplant organs, solid organs, that is, are perhaps repens for these type of conditions, and they need to be looked into.
Absolutely, absolutely. Immunosuppressed patients are much higher risk. Organ transplant patients, particularly in that case. But immunosuppressed patients, in our case here, it's like, of course, organ transplant, as well as like patients with different cancers receiving chemotherapy, immunotherapy, etc. But it's important to note also the immunosuppressed patients also includes patients that are on biologics, for example, right? Like
That's
GI
right.
physicians who have patients on like different biologics for their Crohn's or their ulcerative colitis. Those patients are also immunosuppressed. So looking at their skin at least once a year, skin exam is recommended.
Absolutely. Doctor, I would be remiss if I don't talk about, from the public health standpoint, something that has affected a lot of individuals in the community, and it has to do with the HPV virus. None of the skin conditions that you described today, but I thought to ask you, especially in those individuals that carry the virus and they have had already signs of a potential either condyloma or simply a carrier for HPV. We know how important it is to identify some of the virus trends, especially in women, for the prevention of cervical cancer. Does HPV manifest anywhere in our body other than in the genital areas?
HPV actually manifests anywhere in the skin. It's very, very common. Thankfully, most of the manifestations are benign, right? Like there's hundreds of types of HPVs. So all of our like regular warts, like the classic warts that we see, flat warts, all of that, it's HPV virus. But thankfully, those are benign and those do not lead to cancers. And even condyloma, thankfully, also it's most of the time the HPV subtyping that does not lead to cancers. However, it is actually a risk factor for skin cancers too, which is a good point because that was not in this slide of modifiable risk factors, but it actually HPV is actually also a risk factor for squamous cell carcinoma in the skin. I've seen
Right.
penile lesions from squamous cell carcinomas in the genital area that were originally from HPV infection. So it's important to remind patients also to vaccinate, right? Now we have easily
All right.
accessible vaccine. And that vaccine, unfortunately, it's just for the high risk HPV. It's not for the ones that cause regular warts or the regular condyloma. However, there's some case reports and some studies that actually show some cross talk. So patients that have been vaccinated are more likely, although not 100%, but more likely to clear even the regular warts because it is within the same family, even though it's not the same HPV.
What an important point you just made. But honestly, your presentation is not simple at all in the sense that it is complex in its entirety. Simple in the way you presented it. It's absolutely phenomenal that you reminded us to look into the ABCDE of a particular lesion. That helps tremendously, especially student doctors and primary care providers that are not necessarily always up to speed with the different conditions. But when in doubt, please refer to your dermatologist, to your Mohs surgeon if need be, and the likes in order for them to assist you. Doctor, do you have any sense of, or have you been exposed to individuals that have suffered from melanoma, in the first stages that manifest in metastasis to other areas aside from lymph nodes and brain and lungs and stuff like that? Is the risk, the potential risk of advancing the disease or the disease progression, is it that aggressive that can alter other organs, or this is a soft and smooth and Latin type of manifestation in other organs?
No, I have seen it, unfortunately. So it's not always no. There's some melanomas, they're actually very slow progressing. Patients don't read textbook, right? But classically, lentigo maligna, which is the one that's more like
Hmm.
associated with like sun exposure, classically that's more like a slow spreading, slow evolving melanoma. But the other ones, they can definitely be more aggressive. Um, Most of the melanomas, thankfully, when we diagnose in an earlier stage, surgery is curative. But yeah, no, I've seen cases that even with a thin melanoma that that later on led to metastasis. It's not as common, and now thankfully we're having additional testing that can be done in the specimen that would test like the DNA and then like the characteristics of the tumor that help us, like even with the very thin melanomas, which are not yet recommended for sentinel lymph node biopsy. But if you do those additional testing and you're showing a high risk behavior, you might be a little more aggressive in terms of treating those patients. So I think there's a lot that's coming and has really, it's daily changing like how we go about treating these patients, and it's really changing patient outcomes.
Fantastic. I have a question here. It says, aside from exposure to UV radiation, is there any correlation between heat or the use of chemicals such as dyes and bleaches with the increase of case of skin cancer?
No, heat, not that I'm aware of. Heat for sure, no. There's no, I've never seen any reports with bleaches or dyes in terms of skin cancer. There are other risk factors that I did not mention, like arsenic exposure, things like that. But heat and dyes directly, no.
So pizza makers are still okay. Look, our entire team that has logged in today, Dr. Ruiz has been having issues with her camera. It's not that she doesn't want to show her great personality in camera. So she had apologized before we started that she might go off screen. But in any event, Dr. Ruiz, what a brilliant presentation. And I wanted to ask you before I let you go, because I know you're busy. How effective is our Vectra machine at MCI? Does that help us map and identify tissues that are not supposed to be in our skin? How do you feel about Vectra?
I think that's why I actually brought up that slide with AI. It's of course a different tool, right? I like Vectra a lot. I think it's an excellent machine. It's done by Dr. Bergioli's team is the one that does it. I think similarly to the two that I brought up in the presentation, it's another tool in the toolbox. Okay, it does not replace the human. So basically, for those who do not know, the Vectra is mole mapping. So basically, it's like several cameras that take 92 photos at once of the patient's body. So you're able to know baseline where all the lesions are. So if you're noticing like something changing, like I said, like changes is very important, something is new, you can always go back to like the baseline picture and see like, was this there? Is this changing? And then we can also do like dermoscopy pictures. So it has AI assisted with it, but it does not give you diagnosis, and it needs a human looking at the lesions and doing the skin exams associated with it. So I love it. And I think particularly for patients with history of melanoma, history of multiple, like atypical nevus syndrome, because they have so many lesions, it's really hard to keep track, right? So for those patients particularly, especially good, but you still need the full body skin exams every so often, depending on your risk factors. So it's excellent, it works great, but it still needs your dermatologist, or and you
Absolutely.
still need biopsies when the lesions are concerning.
It will never replace your expertise, Dr. Ruiz. Thank you so, so very much on behalf of our entire team at Baptist International for accepting our invitation, for your phenomenal presentation, and for participating today. And to everyone that participated, thank you for your questions and attendance. If you have additional questions or you're concerned about one of your patients or your own skin, please let us know and send us an email to BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We'll make sure to forward those to Dr. Ruiz for her assessment and get back to you promptly. We look forward to seeing you all in our next oncology lecture series, and we will be sending a date and time for you to log on and participate. Once again, thank you. Have a great evening, and thank you once again, Dr. Ruiz. You're fantastic.
Thank you so much. Have a good night.
You too. Thank you.